trauma is the umbrella under which I see people who may or may not be HIV. So I am going to tell you what I think about trauma and hope that you'll make that adaptation and perhaps ask questions and we can do it together. I just wanted to sort of say also Ethiopia. So this weird, extraordinary, life is unpredictable. And I have this great honor of working in Ethiopia. More importantly, perhaps, taking amazing people over who teach for a month in various disciplines. But so here I am in Toronto doing trauma, and there I am in Ethiopia doing other kinds of stuff. And I think for me, the link is that if we think of poor old Haiti with that dreadful earthquake and the disaster that happened and continues actually to be unresolved, we look at what infrastructure does. So when disaster strikes, God willing it doesn't in our town and anywhere, but we're never going to be as bad as Haiti because we already have wonderful infrastructures and networks and ways in which we will rally and do whatever we as individual therapists and caregivers can, when the CN Tower topples down or when something awful happens. So for me, the development of infrastructure, I'm a clinician. I just like talking to patients. But insofar as you get involved in infrastructure, I think good infrastructures are what enables healing. It probably prevents bad things or mitigates bad things, but it also it's a very important component of recovery and healing. So I want to talk about, I've sort of divided this talk into a few sections, and I sort of get into my dissociative state, motor to the end, the clock says 11, and I've put in pauses to make sure I stop for questions, comments, suggestions. So I'm going to first of all talk about what's traumatic about trauma. Why is it different? I mean, life can throw some pretty curved balls at all of us, but I want to be picky about what actually is different about trauma to grief, to chronic neglect, long-term bad treatment. These are all, it's not a competition. Like trauma isn't worse or better than grief or neglect or whatever. It's just different. These days, in our vocabulary, Summerfield is a very interesting psychiatrist and theorist about trauma, and he says, just listen to our language. Like I find myself saying to friends, oh my God, I'm so traumatized. That pair of shoes that was on sale have been sold. It's like, what? So we medicalize very quickly stuff that's we modify and medicalize our experience or experiences in the world, and that has some effects that I'm going to talk about. So I hope it justifies my pickiness about what trauma is, and that I hope will help us provide better care or validate the excellent care that's already been given. And then I want to shoot holes in PTSD. You can't really turn on the radio these days without hearing that it's a diagnosis that everybody uses all the time, which is good, but it also has some sort of major problems with that. And then I want to talk very briefly about dissociation, which is a sort of forgotten twin of trauma. And then pause for questions. And who heals? And why is it that some people have a harder time from healing? And what exactly does need healing? And then this sort of extraordinary, I know you've had John Hunter, and he's at Sinai too, and he's a wonderful colleague and friend, but he talks about mentalizing. So mentalizing is this extraordinary ingredient, which is about resilience, and it's also about care. Oh, thanks, Mark. Thank you. So what the heck is trauma? We often think of trauma as being torture. I work at CCVT, Canadian Centre for Victims of Torture, and that's a room where torture has taken place. It's very scary for us, but as citizens, we have to know about these things, I think, because it's one of the onuses on us as citizens, as humans, as human beings, particularly perhaps as caregivers, to advocate against societies, our society, other societies that propagate unspeakable trauma. But actually, the more common trauma that we see at CCVT are terror states, where people are persecuted for their ethnicity, for their religious beliefs, or for other particular aspects. And I want to make that sort of, I don't know how well you will feel about this, but I sort of want to make that terror state idea also something that we have to think about in in our own situation, where there are children who are raised in terror states, if you like, where what we do to children can be as damaging as any of these things, perhaps more because they're developing. If we have good enough homes, it's remarkable what human beings can bounce back from or manage to adapt around. But if you have a bad upbringing, and I'll be very specific about what I mean by that, but I just want to make that sort of terror state analogy. All right, so what's traumatic about trauma? Oh, that looks like it's not quite on. Yeah. I mean, that one's okay. We've got all the essentials on there, almost all the essentials. So the thing about trauma is it happens. Usually we talk about trauma when we mean an event. An event happens, and you're just so reliant on your your mammalian skills that you're not really there. So here we are. I don't know if you can see that dotted line. There's a dotted line. This is hopefully where we are now today. We're kind of, you're not really probably, if I say now, listen to the sounds in this room. Oh yeah, there is a buzzing, there is a clinking. But it's this wonderful ability to be safe enough to tune out stuff that doesn't have to worry you and do what you want, focus. You're also probably thinking, what's for lunch? How will this fit with my group of patients or clients? You know, like you've got your associative cortexes, you've got your frontal cortex. So you're kind of the you of you, the individual that you are from your own history and your own background and your own opinions and thoughts and ideas, which is lovely. But if there were a sudden explosion and we were suddenly catapulted into the, to black, I mean, luckily it's daylight, so we would have some, but if something horrendous happened, we start to be able to function and survive, not based on our frontal cortex, but based on these other components of our brain that we share with, like not even mammals. Our sort of midbrain, brainstem and midbrain is more like chicken brain. And then limbic brain is more like dog and horse brain. And then we've got our frontal cortex. But you're offline. If the trauma is sufficiently terrifying, we don't need our frontal cortex. In fact, it's a bit of a problem. So quite naturally, we go into survival mode, which is flight or fright, or sometimes freeze. If there's an explosion, we've got a high adrenaline state, freeze. We're waiting for more information. We don't know if to run, hide under the table or run out. So suddenly we're just very successful mammals. I mean, like, we don't have fangs, we don't have claws, but actually, there are problems now because we're the most successful species on the planet. And this is why, I think, this is one of the very clear reasons, because we're very good at surviving scary things. It's important that, I think, terror in and of itself doesn't traumatize us. You pay money to go to awful films, right? And it's kind of, you kind of cuddled with your partner and you don't look, or you do look, you're playing with fear. You're dosing yourself and you have complete control. If you hate it, you can turn it off or leave or whatever. I'm really talking about situations where you're terrified and trapped, right? Something happens to prevent you being able to be in charge of that fear. And that's a sort of dose. That's what has to happen if we're going to talk about trauma spectrum disorders. I mean, I guess I could, let me go back. It comes up later again, but of course one is a bit patchy. Supposing we had a fire in this building, there would be, if it went on, let's say, for an hour, there would be, or even less, but there are ways in which one goes in and out. You're not just suddenly dog brain only. You're moving in and out of, oh my God, I thought, and then back to survival mode. One of the important things about that is because you're functionally offline, because your frontal cortex is functionally mostly not working, you take in that experience with the brain that is there. So you don't remember the experience of the fire like, oh yeah, I was sitting there, I was thinking about this and that, and then suddenly I had it. You don't have this explicit, well-organized, symbolic, meaning language is symbolic. You don't have that kind of way of remembering it. What happens is, like, I have a young woman who was caught in a fire in a high-rise, and she comes in to me and says, I can't go by subway anymore. And I say, I'm thinking, well, no wonder. It's dark, it's cramped, it's lots of people. And so I say, is it because it's dark, cramped? She said, no, I don't think so. I say, okay, so what is it? Let's walk you. She says, well, I go to the subway, and she goes to one of those subways which has, from the sidewalk, you go downstairs, right? That's her subway. She says, I go there, but I can't go in that entrance. So she can't even get there. And what, of course, I don't know if any, have you figured out what it is? People have their last cigarette around. She couldn't walk through that smoke because it reminded her of the fire. She didn't even know she couldn't walk through it, right? So that experience of the fire for that woman, and that's the sort of, in a way, the point of one of the points of differentiating trauma, is that the information isn't accessible. She doesn't say, oh, of course I can't go down that entrance because smoke frightens me now. Any smoke. She can't do that because it's not really stored in the kind of place where you can do that. And one of the most important things about trauma is to help somebody figure that out, find it in themselves. And, we do that all the time, right? For me, the metaphor is scaffolding. I need to try and scaffold somebody, a lot or a little, to help them develop their own kind of understanding of their experience of their own selves. So I'm just going to give you three major ideas about why is trauma different, what is traumatic about trauma. So that's the way in which information is stored because of the way we work under huge terror. It's organized differently. It's in procedural memory, for those of you who care about, neuroscience for what it's worth. It's very naughty of me to say that. It's very trendy. I'm always grateful for Ruth Lanius, who's a friend and colleague, who always says to me, oh, Claire, you know us FMRI people. We're just validating what you clinicians have known for hundreds of years. So I love that. But it is, so procedural memory is what I'm talking about. And explicit memory is what we need to help our clients get to if we're treating trauma. Another idea is that we've all heard about attachment, right? Attachment systems, there are different kinds of sort of styles of attachment, and that's great. The theory on that is terrific, but it's just it makes us think there's only one kind of system like that. But there are very interesting theorists, both in psychoanalysis and in animal behavior systems. So Pancept is one, Yuck Pancept, if you ever feel like reading a book like that. It's very small print, and it's all about how you do horrible things to animals. But you do actually come out of it with some very helpful information. And that is that we have various emotional motivating systems. So if I were skilled enough, I could tell a joke and make you laugh. If I were skilled enough, I could say something that would make you frightened. You would look slightly different. I'd know if I had succeeded. If in the break, when we stop, you'll start to talk to your friends and network, and you'll be social. If we hear a baby in the corridor, you tune out that little cry. But then if it happens again, you start thinking, what? And then if it continues to happen, somebody will get out and sort it out. There's a caregiver circuit. Just like there's an attachment circuit. It's triggered by different things. So what triggers attachment? Does anyone want to be brave? Fear. Fear triggers attachment, right? So a crying baby will trigger caregiving. Getting up and being with your friends and colleagues will trigger our socializing circuits. You've had that experience probably when you felt miserable or sick or something, and you don't want to go to the party or the gathering, and your friends say, oh, no, you have to. And you do, and you have a good time. And you think, that's weird. I really was feeling awful, but I actually did like the socializing. So they're different circuits. They smoothly engage, or should do. And we're kind of unaware of it. Although as caregivers, we do watch posture, right? If somebody comes into the office like that, or we try and read people, and that gives us some degree of understanding of these kind of emotional motivating systems. So if I make you feel amused, I will see that emotion will motivate you to whatever. Maybe it should be emotional behavioral system, but they call it emotional motivating systems. The thing about this is when you're afraid, or when you're chronically afraid, it trumps everything. So I have a patient of mine who taught me this. We'd been working for 2 years. She had been quite badly abused by priests in that system. And I remember one afternoon I was working with her, and the sun was coming into the room at my eye level. So I said to her, would you mind if I just get up and turn the blind? Because I can't really see you and concentrate, and I'd appreciate that. She said, yeah, no, sure, because it was right near her, right? So I went up, turned the blind down, those blinds which are organized inside the window, just turn. And then I went back to my seat. It's a fairly small office, and I looked at her face, and she looked terrified. And I said, what's happening? And she said, I thought you were going to rape me. Now, she's a middle-aged woman. I'm a middle-aged. It feels like, what? Luckily, I didn't say that. I think one of the things to do about people who are overly organized by fear is to be absolutely direct. No, I'm not going to rape you. Not now, not ever. Can you tell me what that's about? So, first of all, no. I understand. Thank you for telling me no. No coercion, no rape, no nothing here. You are sexually safe in this office. Are you sure you feel like? Do you feel safe? So you want to make sure that a person does process that experience. But I asked her why then was she, was this new? What happened? And she said, oh, no. I've been frightened about that since we met. I've only now had the courage to tell you. So I think that epitomizes what I'm talking about. People who have been in sort of terror states, fear situations, and I'm not talking about refugees. I'm talking about people who are raised in families that were very frightening, or families that weren't frightening but failed to be protective. These guys are frightened most of the time. You know the kind of client who walks into your room for the 500th time and says, "Is that a new picture?" You know, like, there are many ways to think about that, but one way is to think they are only now being able to look around. And that's our default emotional motivating system. If you go to the airport, dump your heavy case, sit in the, I don't know what you call lounge, no, the big environment that airports provide us with, you know, you may sort of sit there and watch people for a bit. You may go to the newsstand and check out the newspapers, magazines. You might scan the food court, see what you... Maybe you will focus... Maybe the smell of a Cinnabon. I mean, who eats those things? But they suddenly appeal. There you are. So you sit down, you eat your huge bun, and while you're sitting eating it, although you weren't hungry, you know, it appealed, you sat, you ate it, and that switches off the seeking curiosity. You finish it, you've enjoyed it, you get up, and then... So this seeking curiosity is our extraordinarily useful default state, and that's really what you want to see happening in an experience with a client. You want them to be, oh, okay, so this is a new program you're referring to. Oh, you know what? I found myself, they're being curious on the inside, they're being curious on the outside, they're engaging you in this kind of, it's sort of like the perfect inside-outside relationship, where you're open to new things, you're not frightened, and it's very highly resourced. That, of course, is not around for chronic trauma patients. And this is the third thing to remember about trauma patients. So this is Ledoux. Read anything by Ledoux. He's wonderful. And he, you know, I don't know what your disciplines are, actually. I know that Maureen told me that you were a mix of different disciplines. I don't know how much time in your discipline you spent talking about fear states, but if you're like psychiatry, you spend endless years learning about depression, whatever that is. I mean, depression is actually a geographical state, right? I'm not sure that we know a whole lot if we just use terms that don't engage with our inner life, but we don't talk about fear a whole lot. Ledoux does, and he has an extremely good book about fear circuits, and very accessible, very well written. It should be on every curriculum in my mind. So this is one of his ideas, one of his elucidations. It's not his idea. It's a biological fact. So you see a little picture of a man he's walking in a forest, and he's lifting his leg, or about to, over a log, and he's looking on the ground after the log, and he sees this. Yikes, is that, what is that? Is that the snake? Is that leaves? And you see his eyeballs wondering, oh. And you see two circuits. You see a very quick circuit from the eyes to the visual thalamus to the amygdala, which is a flight-fright pathway. It pumps up all the components that we need to run or to fight. His muscles, his heart rate, his blood pressure are all ready. He's suddenly scared. But because he's not traumatized, he waits. And you don't have to wait that long, but you do have to wait a little bit to have that visual image clarified by your visual cortex. And yes, indeed, you can see the little picture. One is this not sure yet, but let's prepare for the worst, fast pathway. For the slower pathway, you see this, oh my goodness, it is the Mississauga rattler. How fascinating. How often it gives you what we want our traumatized patients to have, which is choice. Mostly The problem with trauma is they don't have choice. Something happens, bang, they've reacted. Somebody looks at them funny, they're fighting. Somebody doesn't look at them, ignores them, they're suicidal. I mean, these are my dear clients are like that. They have a feeling and it becomes a call to action in nanoseconds. And one of the things to do is to do nothing, right? My patients are always saying, but what do I do if I feel angry? What's the point of feeling angry? Well, there's nothing I can do about it. And I say, well, so let's not do anything. Like, doing is actually the least useful thing with these fast circuits. I'm sure they were useful if one were, God knows, in Syria or somewhere awful. You want fast circuits because you want to survive. But after the trauma has gone, what was very helpful is now ruining your life. So that's really the three, those are the three biggies, I think, that what makes trauma traumatic? What is it about trauma that separates itself from grief or from other kinds of awful experiences? And I've put those three in, and this little kind of thing we made up, we pulled it together for the book, and we divided the defenses, the fear defenses, into sort of flight and fright and into dissociative defenses. But I'm really just going over at the moment the flight and fright, the good old-fashioned fear circuit. It's not really linear. I mean, we all these things one makes look more linear than it is. But, if we're upset, if something happens here, we'll all get out our cell phones. There's somebody in your life, you know exactly where they are, and you know their phone number, or you know exactly how to get hold of them. Because that's like the equivalent of little lambs bleating in the field, right? We cry out. That's a very useful and first step. Shalev, a brilliant theorist in Jerusalem, when there are awful things that happen in Israel, he says he doesn't worry about the patient in the emergency who comes in screaming. Because, we call somebody's screaming, it's like, well, where's her mother? You call your tribe to look after you. He says what he worries about is the person who comes in kind of quiet, asking for nothing, not really processing much, but easy to ignore. So we shouldn't pathologize unnecessarily. I mean, when people scream in my room, I do say, you're going to frighten the patients. Please don't do that. And I can't hear if you scream because I'm frightened too. So let's, it's not that we have to foster behavior that will be detrimental to our clients. But maybe Shalev has a point that we have to think about what it is that actually requires change. And so I shaded out, just as I shaded out the dissociative component of the new PTSD disorder in the DSM-5, I just emphasized the parts that are exactly about what I talked about. That's the fear stuff. So why do we have shaded out parts? That seems a bit odd. Even in the DSM-4 PTSD, they had 14 associative features. So actually, as it turns out, although I believe in what I've told you, but it's not pure. Trauma is never kind of this pure fear state that has these symptoms. Actually, it's a messy kind of thing, and I hope to tell you why. Here, social withdrawal, hostility, dissociative symptoms, self-destructive and impulsive behavior, guilt, auditory hallucinations, and paranoid ideation. So it's a messy thing, but I started with the kind of pure trauma bit. And this is just to say what I said before. When people have unrecovered and have not adapted to the awful stuff that has happened, adaptation doesn't mean agreeing with. It's about accepting reality. So-and-so was raped on January the 1st, 1985. As horrific as that was, it's a fact in their life. And so that's an important component in order to develop choice. If your only way of knowing about that horrible event is because when you go into an elevator with a bald-headed man, you find yourself in a state of terror. That's a sort of procedural memory, automatic behavior. And that's hard on people. What we want to do is for them to know themselves, to figure out, oh, of course I'm frightened of bald-headed men, but this guy in this elevator looks okay. That's what we want. That's really about all we can do. We can't lobotomize. You can't remove the memory. What you have to do is to, like some people, patients, as well as faculty or whoever, caregivers, think of trauma sometimes as a splinter. I was fine and then this thing happened. If I can just get it out, if I can just tell you everything, despite my highly hyper-aroused state, I'll be okay. But the analogy is wrong, right? It leads us into the wrong. It's more like a bad blood transfusion. Nothing can remove that experience or that way of having something come into you. It's part of you now. But it doesn't have to, if we're talking about trauma and an analogy, it is, in fact, people surprise us all the time by their capacity to transform their lives. So I'm going to say, is PTSD enough to describe what happens in unresolved trauma? Is it the event or is it the meaning of the event? Yeah, you know, like any of us who've been in one job for 20 years, you see the sort of fashion and the waves of ideas. And when I was started in trauma, like the thought of asking somebody about, people would be very scared to say, well, you were raped. Do you want to talk about it? Okay, please go ahead. Tell me what you think you can talk about easily in 20 minutes and we'll do more. You know, like that was unheard of. Now, if you check the guidelines, you're absolutely right. In all the Western guidelines, Australia, England, Canada, the States, they all have the requirement of exposure for treating PTSD. And in fact, if you don't expose somebody, it can be awkward, for instance, in the legal system. One of my colleagues got raked over the coals in a court because he was treating a sort of fairly high-profile refugee, and he said that person had PTSD and he treated him, but he did not do re-exposure or exposure therapy. I think one has to bear in mind that you have to check who's afraid most. Am I afraid of hearing what my patient's got to say, who's actually endured it? Or are they afraid, in which case I need to help reduce their fear state? We've written about, we really believe that exposing torture victims to the torture again doesn't benefit them a whole lot. There's not a lot of research on that. It's more like the negative. If you look at all these guidelines, which are fabulous, and they're really seriously researched, these meta-analyses, but none of them are refugee patients and none of them are refugee therapists. So it's good evidence, but it's biased evidence. So that's why we felt we could write about, without evidence, we could say, look, sort of negative. You haven't really thought about refugees yet. So let's not force everybody into an exposure experience. So I'll zoom on, shall I? Anybody else, sorry? Yes?
Is it different for you when a client presents with a traumatic event as opposed to living in a chronic
event? You're anticipating the sort of crux of the whole thing. Yeah, I think that there are two ways of, I think it's good to think about two things. Event traumas that happened on this date, this time, and lasted this amount of time, even if they go on suffering. There's a book just written by a professor in Guelph, and she calls it 1 Hour in Paris. It's actually an interesting book to read. It's a short read. It's about a rape she underwent in Paris, 1 hour. So that will be a typical event. But yeah, no, people live in terror states. And that has a kind of an effect. I think that that's the poison, if you like, because if you are, and I hope to show you, you are ill prepared if you haven't had an adequate caregiving environment growing up. You're very ill prepared for an event, and there will be events. We can guarantee in our lives there will be events that we don't want to happen.
They're not there yet.
Well, you're right. One has to be enormously tactful, because it's not for me to say to somebody else, you know, this is the opportunity of a lifetime. But as therapists and as caregivers, we can introduce ideas. We don't have to force them or even hold them if they don't find, if the patient doesn't kind of agree with that or agree with that at the moment. But I do think there's this double, I see it with refugees, there's this sort of double curve. When they're new to Canada, refugees need to learn how to work the laundromat, figure out what to wear for an interview. That's the crucial ingredient of being able to settle. No matter what torture you've been through, it's the present that people have to help them with. They don't want to talk about the past. They don't need to do, they need to have a present. But 10 years later, there can be a wholly different kind of experience with a refugee, I found, where people come back and say, look, about Rwanda, about what I went through. I've learnt the language. I've worked for the first time in my life. Here it's safe to work. I can do, and now it's April again, and I'm remembering the genocide. Not remembering, I'm standing in my bathroom, not being able to move for 12 hours every night. So people, it does come back. And I have that feeling that that's how we're made. So cautiously and judiciously, with all one's skills, one sort of has to say, well done. Good for you. Sounds like you're feeling safe enough maybe to process a little bit more of this awful experience. Because it's a lifelong thing, right? We continue to relook at our lives as we go through different stages.
Thank you.
Okay, so I should say everybody's been through bad stuff, so please protect yourself. If there's stuff I'm saying that does not feel right or feel frightening, please, you can always slip out. Nobody will know why. So don't feel, I just want you to, it's sort of like a caution. I don't want this to trigger people. I do want us to enjoy the privilege of learning from other people's experience. So here's a typical thing we see in the news every day. Some poor person is being wheeled out after some disaster. This happens to be in Africa, but people are left homeless. They take what they can and walk away as hard as they can from really bad situations in Europe. This is a favourite picture of mine. This is all, I don't know any of these. I can only project onto these pictures. I have no personal, I picked them out of the internet. But what's happening here? Sort of hearing ceremony, I heard ceremony. Like it's a tragic death of a little child, a baby, right? I mean, it's what's interesting, I think, and what we have to think about with this sad and important moment is how it differs from trauma. Like, I don't know this man's ritual or the ceremony that's going on. All I do see is there are a lot of people who are paying attention and who are sort of respecting this moment in time. That's not what happens in trauma, right? You run out of a nightclub and you stand on something soft and you don't know if you've helped trample somebody to death. You know, like it's so disorganized. Whereas this, in a way, is how we heal. The trouble with trauma, remember, it's all on that kind of procedural memory thing. It's the smell of smoke. It's the feeling of hands that aren't on you anymore. It's the tastes in your mouth that trigger, right? Here, grief is probably, hopefully, the prevailing emotion. So with procedural people who only register their experience on that kind of somatic memory need to get to grief, right? When you can get to grief, we all know grief, and we all, as caregivers, as therapists, can exhale, because somebody who can grieve with us is a actively healing person. Grief, I sometimes say to my patients who say sorry when they cry, this is why we have tear ducts. We're built to grieve, right? From the beginning, we lose stuff. We lose our mother's body. We lose her carrying us around on her hip. We learn to walk and we go to school and we lose. We have losses all our life. People, no one been dumped in this room? We have loss. We fail exams. We get dumped. People die. And yet, if we can grieve in our own way, according to our own rituals and capacities, we have more room to let new things in. If we do, Queen Victoria, I don't know, she wore black all her life after losing Albert. That was not a cultural requirement. But the question is, did she ever really mourn him? So we want to help people get to grief. Grief is our home territory as therapists. Terror state, this is an apartheid picture. I love this picture. This is also a man, an ANC member, carrying a coffin. What I love about this picture from my own thoughts is his face. He is showing us, I don't know what he's feeling, but he is not hiding his feelings from his facial expression. All my patients look lovely, pleasant, and I have no idea what they're feeling. It's one of the things about chronic trauma. You learn to hide. You learn to hide in full sight because you've been raised in a family. If you did cry or say something, somebody would say, I'll give you something to cry about, or something similar. So the power of this for me from my work is that our hearts can go out to him. He engages us in wanting to sort of understand something or feeling sympathetic or compassionate towards. And that's what our faces are for. That's what the neuroscientists say. You have a feeling, which is a physical thing. You know you're terrified. You see a lion. You go into complete physical response, emotional motivating system. And then in a sort of flash, that says to your brain, oh my goodness, I'm terrified. And then it shows on your face. I mean, you do something, you hide or you run, but it also shows. So if there is a lion behind you, and I start going, you have a heads up, right? You have a little bit more advantage because you've read my face. And that's why we're built for community. We're made to engage with people through our faith, which is what he's doing. But my clients can't. It's lovely when they get pissed with me, finally. Dr. Pain, I didn't like what you said. Like I said, hang on. They haven't required admitting for acute suicide. They're actually, they believe that we are two humans and they can say, that made me laugh. I didn't like that. And it's like, it's a very nice thing when people feel safe enough to share their emotions via their face. So that's that a little bit of complexity, this lugging your belongings, having had to move, all of that is beginning to be recognized in a much broader PTSD diagnostic criteria in PTSD in DSM-5. Remember, of course, the thing is function. I work in Sinai, like an awful lot of the elderly in Sinai, or the people my age, they're children of survivors, but the survivors themselves have probably had nightmares every week of their life, having lived through the Holocaust. But it didn't stop them opening a business and having children. It's like function is the key. without function, people are very, very in need of our services. Our job is to optimize function. Okay, dissociation, fairly briefly. Ooh, sorry. In the old days, it didn't exist. I mean, it did. But people had a hard time. We knew as clinicians, but it was not sort of identified in a evidence. It's hard to sort of chase. Now with FMRI, I'll show you now, and it's Ruth's work. We can be proud of the fact Ruth Lannis is this amazing Canadian who lives in London. It's actually her work as a resident that has changed the DSM-5. So we now have this specifier in DSM-5. You can have a subtype of PTSD which has dissociative symptoms, either depersonalization or derealization. Delayed expression has always been there. That's not new. And this is what I'm talking about. When you can't escape, when you are a child in your family and you know you're going to have something really weird happen most nights, you develop ways of evacuating your emotional experience, which is probably what dissociation is about. Some things are too frightening to be present for. And if they're predictable, we little mammals develop ways of managing, even when we can't run or fight or get out of the situation. So the freeze is not the high arousal freeze, it's the low arousal freeze. It's like clonk. And you've probably seen this in your offices. People just kind of clonk and check out. They still look fine-ish, but if you notice, they're not really so present. If you say, hey, come back. Where are you? Are you there? Come back. Which is, people can come back just like that. It's us who have to observe it or check. And if they come back, and I say, what happened? What happened? And they say, oh, I don't know what happened. And I say, well, what did I say? What happened here that made you check out or zone out, whatever expression they use? And it may have been something I said or a memory, an external or an internal trigger. But it doesn't necessarily mean there's a multiple personality, right? I want to separate. A lot of residents always think that dissociation means you become someone else. No, it's just a measure of affect regulation that sadly people have learned under very difficult situations. There's some of these that aren't necessarily pathological. You know, you hear about stories when somebody has a heart attack. They drop to the ground and then actually they're sort of sitting up in the tile looking at this lady. And somebody's called the crash cart and people are doing pounding on their chest. And there's this experience that they later tell you about. Well, I was sort of thinking, it's a slightly empty. Say, oh, look, there's a lady on the ground having a heart attack. Oh dear. So fairly affect-free detachment. Then they live, and then they can report this as this strange detachment experience they had during a crisis. And we have that. You don't have to have been chronically traumatized to have that. But if you have been chronically traumatized, it's like you know how if you flip your shoulder, if you dislocate your shoulder and don't get it fixed, it can flip out easy. You hold onto the subway and you flip your shoulder. It's a bit the same. You learn these defenses under very difficult circumstances, and you sort of have to unlearn them or unuse them because they can ruin your life. Every time you go in for a raise, doing good work, you have to approach your boss and say, you know, I'd like you to consider in a proper way to ask for a raise. If you flip into detachment state or zoning out free state because he's a guy in authority, that is no longer adaptive. So, and I say that to guys, I don't doubt this saved your life. It certainly saved your personality, your values, all that matter to you. But how's it going now? Because they're not adaptive. And that's what we're interested in doing. Not criticizing the need, but helping somebody. I sometimes say, it's like, not that I know anything about computers, but you need a new program, a new words program. You just have to sort of update your software. Okay, so this is Ruth's work, and I love it. It's well published, so this isn't confidential, but this was a couple. I think probably for the interest. These, if you want these slides, you're welcome to them. Nicole has them.
Yeah, and there's on each table there's one printout. I don't know if or you can email us and we'll send them.
So this guy, it was a husband and wife, and they were on that awful road from London to Windsor, and there was this pile-up of 200 cars. It was foggy and slippery, and it was really dangerous, really bad. Anyway, he managed to get out some kind of tool and knock the window out of the car, drag his wife, and go to safety. They went to Ruth, and they told the story, and she said, "Can I put you in my FMRI machine?" They said, "Sure." So the script, the story that they tell her, is then read back to them when they're lying in the MRI machine. And that's how come you can see what their response is. And this is the guy. When he thought about this experience of his, he was right there. He said, "Oh, I have to," he's even in telling the story, he was sort of reliving it. And you don't have to know anything about fMRIs to just look at that. This is the guy who was in a flashback experience in response to a very traumatic experience. His wife, who actually had a mum who had panic attacks, and she had some postpartum depression, right? So family history of psychiatric history in her family, and her own experience of a mental health disorder, two very important variables. And this is her fMRI. Do you need to know anything about fMRIs to see that? Okay, so she checked out. When they read her trauma story, again, she'd gone. So she dissociated under trauma. Her husband, partly she was more of a sitting duck, but, who knows? If she had been driving, maybe she would have picked up different situations, call from us different responses. But it starts to put dissociation on the map in a way that is terribly important. And I love it that Ruth always includes the subjective experience of the patient. So you get the fMRI, and I was completely zoned out and couldn't tell what I was feeling, etc. So you have these subjective responses. And for clinicians, that's very nice. I was outside my body looking down at myself. It was too overwhelming to recall the traumatic memory. I was looking down at my own body while I was back reliving the car accident. So, despite the fact we have a DSM-5, which is trying hard to pin down a more complex experience, I want to read you two important theorists, for me anyway, Arthur Kleinman, who's at Harvard, an anthropologist and psychiatrist, and he says that, you have to be careful of these labels. Social suffering results from what political, economic, and institutional power does to people, and how these forms of power themselves influence responses to social problems. Included under the category of social suffering are conditions that are usually divided among separate fields, conditions that simultaneously involve health, welfare, legal, moral, and religious issues. For example, the trauma, pain, and disorders to which atrocity gives rise are health conditions, yet they're also political and cultural matters. So I think we probably all buy that. The problem is with our system is that we need to call people PTSD or depressed in order for them to get care. And at least we need to be aware from Summerfield, the bad boy of psychiatry in England. He ran the Medical Foundation, which was like CCVT. it was where tortured refugees go in London, England. And he says the use of psychiatric words to describe suffering implies that PTSD is universal and context independent. This medicalization of suffering, i.e., we're putting into one person all this cultural, religious, economic, political weight, and we're saying, you're sick. You have got PTSD. So we medicalize suffering, and it infers that all suffering is pathological. It's all an illness or a disease, and it must be treated within a medical model. It obscures the political and economic causes. So I think we have to be cognizant. We like to help people to hop onto a recovery road or to validate where they already are. But I think we also need, as citizens, to be aware of how interesting it is to be caregivers, because we're engaging sort of where the tire hits the road in a way. It's where a human body engages with the political, economic, spiritual, health systems. So suffering is inevitable for all of us, and traumatic experiences are ubiquitous. We've been doing horrible things to each other since we were human beings. And to heal, we've always needed the institutions of society where meaning and culture is sequestered. So this is Summerfield's idea. He says, if you look in England, for instance, every village, you will find a war memorial. Every single tiny little village, and you'll find not just a cross in the center of the village, you'll find the names of the young men in those days from the First World and from the Second World. They've been recorded. They lie in the heart of the community. And he says that's what heals us, because it's sort of this invisible vapor, or it's an interesting. It's easier to see in other people's cultures than in our own, but it's when we need healing. What we do is we build more schools for our children. We go to PTA nights. We take part in discussions. You know, the CBC is always having these wonderful. I'm a CBC junkie. The morning show is always having various gatherings to talk about the food bank or the refugees. These are the ways in which we engage the inside with the outside. So mosques, temples, churches, synagogues, work, healthcare, sports, community centres, Casey House, pubs. Not to drink your face off, but to, gossip with your neighbours. Right? That's where meaning is. So he says, be very careful when you medicalise suffering, pop it in one person and tell them that they need treatment. Treatment for all of us is about the interface between me and my community. And that's where healing actually is ongoing, right? That's how we stay well. He says, less treatment. If you go to Rwanda, Francine actually did go to Rwanda, people were running in with PTSD checklists. Actually, what you need is when somebody stopped and said, what would you actually like? They said, please help us build schools for our kids. So it's like, we can always come in as experts, and that way we really double whammy people. Our job is to engage and be dumb and curious about the local resources. I mean, so because I want to answer your excellent question fast, I want to skip to the sort of thing for me about culture, which is my culture is invisible. Other people have cultural, interesting things. I'm kind of Anglo-Canadian, boring, there's nothing much. And then when I go to Ethiopia, suddenly I've been going there for so long, they actually give me some feedback. Things like, Dr. Clare, we know you love us, so why do you shout? I say, me shout? I don't shout. Because when you're there, whispering is... So, number one, all I can tell you about culture is I'm always wrong. I absolutely cannot know. And now I would say, I was thinking about it today, and I was thinking, I am coming into a different culture today. I've heard of Casey House. I've walked past Casey House. I have friends who've been engaged as clients and as caregivers engaged, but it's not my culture. I don't know HIV AIDS like you guys do. So I want to take what happens to other people over there who have different languages to us right back here. I live in Cabbagetown. What do I know of young male gay culture? Although I live practically on Church Street. So, yes, I think I'll tell you one culture I'm quite good at. Middle-aged Anglo-Canadian women. Middle class, I know where they buy their clothes. I can look at their shoes and I say, so, like our actual competence is minute. So all I know is I'm always wrong. And I love the privilege of being curious. Like one can be a little bit more curious as a caregiver than one can be socially. So yeah, no, I'll tell you, if you are forbidden whatever rituals you have, that can be difficult, right? If you have to flee when you leave your granny dying, maybe, I mean, that's hard. Or you can't, or the ancestral burial grounds are destroyed by, there are lots of things that can interfere with that. But I don't know that people who overtly express their emotions are in a better or worse state than those who don't. It's so culturally variable. So who heals? Who heals? All of us have probably had a traumatic experience, but only 5 to 10% of us get PTSD. Interestingly, in post 9/11, the incidence of depression was much higher than PTSD. And that's kind of the thing. We talk about PTSD, but actually, true breeds true. If you had an anxiety disorder before the disaster, you'll have an anxiety disorder worse off. If you were psychotic before, if you were schizophrenic and psychotic, you will be worse, more psychotic. So it sort of breeds true. But if you look at rape which is often taken as this sort of benchmark, a very, very difficult traumatic experience, Shalev and Yehuda sort of looked at who gets better without treatment, and they found that about 60% recovered in 9 months without any treatment. But there are some people who remain unrecovered, and that's a percentage of people we're interested in. And just the risk factors. So if you're thinking about people in your clients who may be more at risk, there are 14 risk factors. But actually, there's been some good meta-analyses on these 14 risk factors, and only 3 are important as pre-traumatic risk factors. And remember the woman with the blanked out FMRI? It's family psychiatric history. Her mum had panic disorder. It's her own psychiatric history. She had a postpartum depression. And it's childhood abuse. So we don't know, but let us, for the sake of remembering those, let's say a woman has a mum with a bad panic disorder who was not able to protect or debrief her daughter following an abuse. The neighbor sexually abused her. And she grew up with an anxiety disorder, or her mood disorder became obvious after the birth of her child. So those are the people to prioritize. But even then, look at that, only 0.2% of the variable. So whatever you're like before, the good news is it's what happens after that's most important. And that's good news because that's our interest. Traumatic severity still doesn't account for a whole lot of variable. It's the lack of social support following that is the problem. Social support, not EMDR, not evidence-based trauma-informed CBT. It's like shoes. It's like, neighborly lunch get-togethers because everybody's... Remember when the electricity went out in Toronto? It was one of the nicest evenings there was. Everybody lit So it's that lack of social support, and of course the ongoing life stresses. Nothing ever happens in once the Twin Towers crashed. There was the anthrax. Bridges were closed over and over again. It was like we get sort of jumpy. Because you think threat is not, who ever heard of one threat? It usually goes in threes. We have these sort of funny ideas about how to protect ourselves. Anticipate 3 and you'll be safer than think you're safe. So it's this ongoing. And refugees, children, I'm sure clients who have one diagnosis, that's what's hard on us. We get no bounce back time. We get no recuperation time. And these are the pictures of the most vulnerable. That little boy in the back is dissociating, whereas his little sister is screaming that their parents have just been killed. So it's that little boy in the back that you have to worry about, that patient in the back who isn't saying much and is a bit sort of out of things. This is a very interesting study, and I'm not even going to tell you about it. I am just going to show you the graphs. You can read it, but it's basically looking at early childhood trauma, that's what they asked, and what happens when you're grown up. And it's brilliantly done. Folletti is the genius behind it. It's nothing to do with psychiatry, but it brings together biopsychosocial for the first time, actually, in 98. We've always acted off that model, but this is some real proof. So they asked these people whose health records were all known, middle-class Americans, 17,000, a huge study. And they asked them, have you ever been, and they asked them properly, but have you ever been psychologically, physically, or sexually abused as a kid? Did you live in a household where somebody was a substance abuser, mentally ill, or suicidal? Did you witness violence against your mother? Was somebody in your household in jail? Sadly, the prevalence is normal. In a middle-class sample, it's shocking, isn't it? Anyway, what they did was they linked this with the risk factors and the disease. We all die of mostly the same things. But the question is, how soon do you die? And what are you doing that ups or downs your risk to die of the same things? Well, so these are I'll read you this. 1 in 9 people had 5 ACE or more. So I guess I should tell you this. This is very elegant. So you can see there are 7 things they asked about. So they didn't ask how many times have you been abused. They just said yes or no. So your score was 0 to 7. So people who had a lot of people, 1 in 9 had more than 5 adverse childhood experience, ACEs, adverse childhood experiences. Women were 50% more likely than men to have 5 or more ACE, adverse childhood experiences. And for 4 or more events compared to 0, 4 or more categories compared to 0, you had a 4 to 12-fold increase in alcoholism, drug abuse, depression, and suicide, or a 2 to 4-fold increase in smoking, poor self-rated health, which is a very important indicator, more than 50 sexual partners, which is, again, can be an indicator, a history of STD. But just look at what it looks like. So 0 is no adverse childhood experiences by their simple categories, and on the other side is 4 or more. This is divided between men and women. This is chronic depression. This is suicide attempts. 4, 5 or more antidepressant prescriptions. Hallucinations. Who knew? Hallucinations with drugs and alcohol accounted for. 7 or more adverse childhood experiences. You've got a much higher rate of having hallucinations. This is done slightly differently. What it means is you've got 8 or more unexplained symptoms, right, from 0 to 8, with the increased likelihood of childhood sexual abuse. That was just analysed separately. Briquet, does anybody remember that? Briquet in Freud's time linked those two. Well, one has to be careful. Links are just links. They're not chains. But somatoform, unexplained medical symptoms can be strongly associated with an impairment of being able to know what's going on. Impaired memory for childhood, smoking, self-defined alcoholism, IV drug use. Look at that. Male children with an ACE score of 6 or more have a 46-fold increased likelihood of later becoming an injection drug user compared to a male child with an ACE score of 0. I mean, we wrote our book because we felt that this is a public health crisis. What happens to children? It sucks. This is where our health dollar goes. We are trying to mop up the difficulties that occur in childhood, and that's where we should be working, right? Not only do you get sick earlier and die of the same things earlier, look at this, teen sexual behavior. So the violet are the higher ACE scores. Intercourse by 15, teen pregnancy, and teen paternity. Absenteeism in your work, financial problems, and serious job problems. So it's biopsychosocial. It truly does. What happens in childhood affects us as not as categories, not as physical versus psychological, but as the whole. And this is the sad, sad truth. You see that pink histogram column. You see very few pink people who have had ACE score of 4 or more. That means that people die earlier. There are only a very small number of 65-year-olds who've had ACE scores of 4 or more. And look how many survive if they've had none. So that's the truth. And we see that perhaps in our Aboriginal people. They have suffered in a way that significantly reduces their life expectancy. So the deal about that is, when you've had a rough time, you do silly things like smoke too much, drink too much, right? Those are risk factors. But even if you manage to sort of take account of those risk factors that are kind of obvious, we know if we smoke, we're going to be more likely to get cardiac problems. Even if you account for all that, there is still this increased stress that's not accounted for by bad habits that will make us die earlier and get the same diseases earlier. Okay, in 5 minutes or less. So by the time I don't have a pointer, or maybe you can see this. So this is PTSD, this bit. Lovely, ordinary PTSD, you get a trauma, you may have a priming event, you have a trauma, you dissociate maybe at the top of it, and then you get sort of flashbacks at night and flashbacks in the day that are precipitated by cues. And these yellow things are flashbacks and the green things are sort of flashbacks at night, kind of nightmares, but they're exactly the same. And then there's this time that passes. Do you know what these are? You do. You do. You may not know my diagram, but as it goes on, what happens? It's like, I just see people on this far end. They are drinking their faces off. They're drugging up because they're trying to reduce the rage, the irritability, and the rage that pops up. They don't want to be enraged. They don't want to be irritable. So they drink or they use stuff in order to damp that down. So I forget to ask about PTSD symptoms because I'm looking at the illness that has sort of taken over or the life that has been derailed in so many ways. A very important fact, I just had to put this slide in. This is a Bosnian refugee slide. And this is, they did it for men and women. I just picked this one. And they gave these, if you look at the bottom from A to U, there's 3 sections, unpleasant, neutral, and pleasant. So they gave these survivors of war cards, unpleasant cards, visual to look at, neutral and pleasant. And they measured their arousal, their sort of skin galvanic response, their heart rate, all the ways in which we measure arousal. And they found, look at the guys with the blue spots, because they're controls, normals, and PTSD people. The guys with the blue spots were quite aroused with unpleasant cards. They kind of went down with everybody else around neutral, but pleasant, they didn't, they weren't responding to. One of the most horrible things that our guys go through, that happens to our clients, is that they daren't enjoy life. I always think that one of the differences between good old, bad old borderline clients and my trauma clients is that my borderline clients, they love me one minute, they hate me, but they're at least relational. You know, when they love me, it's wonderful for both of us. And then, but my poor old trauma clients daren't. They just daren't. They know misery, and that's where they stay. We have a group that tries to kind of help people let pleasure in and see what awful things might or might not happen. Right? It's a risk. So these guys, what our clients have. They can't express their needs. They can't say, I would like, please. My patients carve admit me onto their arm. And they go, and it's like, that's not going to work. Let me tell you how, if you need to get admitted, because it's really hard for people to be very simple and ask for what they'd like and to say no. No, I can't drive you to Mississauga. I'd like to, but I live in Scarborough. It's like, no, it wouldn't mean much to you, but they're overreactive. They feel like they burnt their skin, their psychological skin. They react to everything, even if they don't show it. They feel vulnerable most of the time. Are they impulsive and aggressive, or are they just so panicky they're trying to escape from their own skin, let alone their own feelings? They avoid pressure. And relationships are not easy and not necessarily rewarding. We in the health profession tend to diagnose people with mood disorders. They may very well not have a mood disorder. They may have an affect dysregulation issue. We often call people bipolar, but actually they have that biphasic experience. They're either zoned out or they're freaked out. It is kind of in two poles, but it's not bipolar disorder. Are they depressed, or are they actually got to the stage of grieving? Personality disorders, do they really have a personality disorder? I always find if I ask a person I'm actually feeling trouble with, I say, you know what, how would you describe your own? I mean, I'm not going to ask it in a crisis between us, but I want to know how they think of themselves, how they actually would describe their personality to me. And they're horrible about themselves. They say they feel worse about themselves than they could ever externalize. And that, of course, helps me respect what I see. I see sort of, sometimes I say, I have one person I say, I think when you're really annoyed with me, I get about a 20th of what happens inside you when you're annoyed with yourself. So I don't like it much. So you must hate it when it's against yourself. So for my own countertransference, my patients, I never really think of them as personality disordered. I think of them as chronically, relationally challenged. Substance abuse, question to us. Are we prescribing benzo city, narcotics? These things don't help people heal. Are they actually trying to kill themselves, or are they trying to calm down with self-harm? And with a family history of sexual abuse, you have 6 times the increased risk for suicide. So abuse in childhood massively increases your risk. So ask. I have to show you this. You can guess, what are we looking at here? What do you reckon? Okay, well, who is this group? What would you guess? There are 4 men? Soldiers. Excellent, excellent. So what? I know no more than you know, except I've watched it 500 times. What do you want to say anything about that? They have are they going to shock? Do they have severe neurological illnesses? Are they, something. Yes. Oh, sorry. Take off your specs. Any other guesses? Battle fatigue? Captured? You know, the truth is, I love it that we've got a great range. I don't know. All I can tell you is those guys are trying to tell us something. I have no idea what. So it's the culture question again. I guess I'm just going to have to get to know them. How are you doing? What I've noticed there's something about your shoulder. One has to be very careful about bodies, right? We have this instant shame. But we can do it. So can you tell? Are you aware? Like you, and mirroring it a bit also gets it. We try it on. What does that mean? Or asking the person to go into more. Or you're raising your right shoulder. What if you raise it even higher? Instead of telling them to stop this sort of pattern, you're doing it yourself. You gain information or start to try and find a way to understand what the communication is. So this is the deal. We've DBT, excellent stuff. I love DBT. Wise mind. This is for all of us, you know. That's often the way a day can. We're either super rational or we're freaked out. Like the trick is, right? That's where we want to be. So all my patients can do this. You know, it's like, where is your wise mind? Find it, because it's their judgment. That's that's the gold, right? 2 seconds minus 2 minutes. 5 minutes, okay. What? So I've been saying small t trauma, large t trauma. Trauma is an event, but small t trauma, we call it, it's not particularly, people call it different things. People call it attachment trauma, my least favorite, actually. The hidden trauma. These are Lyons Ruth, John Allen calls it attachment trauma. What I really want us to think about is what happens to kids without somebody who understands they have an inner life, right? Because if you don't raise your kids or your patients to know they have an inner life, you don't get an inner life because they think that it doesn't exist, right? Our job as parents, as friends, I have to say, as conference organizers, I'd like Nicole and Maureen. I know Mark from work, but I didn't know these two guys. Their way of managing my anxiety was absolutely mentalizing, right? I'm not a patient, no. But if we operate on that level, if we assume people have an inner life, make their best hypothesis, we make our best hypotheses, it goes well. It's the kind of, I was scaffolded by those two guys. So mentalizing is this word that tries to identify that as a skill. It's very tightly organized by theory of mind, which is all about sort of neuroscience and philosophical roots. It's not a new idea, but it's probably the common factor in all therapies. So whether you're a CBT person, a psychoanalyst, an IPT person, an EMDR person, a counselor, for a shelter worker, it doesn't matter, like those two guys. It doesn't matter what your discipline is. It's this capacity that makes everything that you are trying to do useful. You can be a brilliant CBT person, but if you can't mentalize, it's never going to work very well. Right? So it doesn't, what I love about it, it's pan-discipline. It's how we operate as therapists. It comes from our capacity to be parents or our experience of being parented, but it's not the same. I am not the parent of my clients. Very clearly I'm not, nor do I wish to be. I have a different role in their lives. But there's some tips that we can pick up. And mentalizing, I think, is one of them. And it's this, I'll show you what it is. It's holding mind in mind. So here's a baby and a mother, or a patient and a caregiver. And that baby, that patient, that client, your friend, your husband, your wife, your partner, whoever you are engaged with, has the experience of being in your mind and wrapped with a bit of you. So particularly in a developing child, if you've always said to your child, no, I think you can do anything you want. You go to school, you have your friends, you love us, your family. I don't see why you can't be Prime Minister or an astronaut, or, like if you have that kind of experience, either as a child or with your children, they kind of grow up with that wrapped around them a bit. So that darker blue is the parent. And I think that's what we do with patients, really. So, well, I don't see why you couldn't get better. I mean, why wouldn't you? You've got lots of motivation, or you're suffering a lot. That's a reason to want to get better. Like how we organize our way of being with a patient significantly affects outcome, right? Put more formally, the therapeutic relationship, which is a black box because it's all about how the patient feels about us, it accounts for 40% of variance in outcome. And that's about our skills. We have to pretzel ourselves like a good mum, like a good therapist, like a good, soccer coach, into being able to enable that person to sort of access their own resources. Nice picture. A good mum, a maternal shield. Her children can curl up in her shoulders and not look, this is so scary. So what do we do? What does this mean? Mentalize. It actually is very simple. It means you always know if your patient is, or every nanosecond of our entire experience on Earth is an emotional experience. So particularly distress, if you notice it, or anger, any emotional affective experience has a cause. It may be a historic cause, it may be a current cause, but you just pair those things. So you're never pathologizing somebody by saying, oh, you feel way too much. Oh, you're out of control. Oh, that is probably the least helpful thing. You say, you are having a really, really hard time. You're screaming the house down. I can't even. So if you could just tell me what the heck's been happening that makes you freaking out. It's just that simple. Whatever emotional experience they're having has a root. And you're doing it already. These are the most effective. You're warm but non-possessive. Our patients don't belong to us. We're responsive. We're empathic. We're accurately attuned, right? We're reliable. We adhere to boundaries, and we share our goals and understandings. A physiologically baseline baby, and that's where we want our patients. We want them at physiological baseline, so they can think and feel and engage with us and relate. That's where sometimes you have to spend a long time helping people operate within their window of arousal. And what you're always trying to do is to broaden it. My patients say, I don't want to feel my emotions that's the problem. And I'll say, well, what about the opera? What about rock? Like everything we actually value in life is about big feelings. So if you've got big feelings, fabulous. Let's just broaden our capacity. And that's actually how it's done. That's how it's not done. And this is where our patients start off with. They're always freaked out or numbed out. And this is where we want them. I've got 3 more slides, Doctor. So you're doing it already. You want to help them to stay in that optimal level of arousal. You want to focus on mental states in the here and now. Like if there's a problem between you, say, okay, so you're having a hard time with me today. What's up? Well, you forgot my appointment. Well, you didn't give me the pills. Like that's wonderful. Challenge the patient's assumptions. I sometimes go into my clients and I've got some puzzled look or frown, and then I suddenly see that I have inadvertently frightened. They say, "Oh, you're very angry today, Dr. Winslow." I say, "Actually, no, I'm not." Well, why do you think I am? They say, "Well, you're frowning." I say, "Oh, you're right. You're right, I am." It's funny because, I had to pick up some mail and I forgot. You're right. So you want to validate what you can about their perceptual competence around. I mean, I never talk about my own life or my own internal states, but I do think that kind of validation in the here and now is helpful. And we don't want to say to it, you know, you may have a very angry patient. You say, gosh, Mr. Smith, you're angry today. I am not. I say, okay, fair enough. What are you? You know, if you attribute, it's annoying when it happens to us, right? So, you know, people attribute, I never, no, I'm not really bored. I'm more like fed up with you. So it's like, we have to be attuned. That's the attunement. And use I think that we're in a bad spot. I think that we could do, I'm worried because I'm not sure I'm getting this. So us. We mentalize us as we mentalize others. Attend to your spirit. We must attend to our spiritual and creative lives. I love that girl. Have one focused, connected, meaningful conversation each day. Relax with your friends. Go on learning to be a team. Those guys did not wake up one morning to be able to do that. We have to work with each other, trust each other, and do amazing things together. We can be inspired by our clients. This is a guy who had a bilateral hand amputation in Sierra Leone because there was a rebel army who didn't want people to vote. And if you look at his foot, what's he doing? He's voting. Like, it's the capacity for people to transform their lives. It's more like skin heals, right? The surgeon cuts our skin, sews it up. I don't know how it heals. Our bodies know how to heal. Our psyches know how to heal. Our job is to sort of see what's getting in the way. You know, if there's an infection, you have to clean that up. It's not going to heal properly. So our job, I think, is to help somebody find the way to recovery, and for our patients, but also for ourselves, our bodies. You know, what we know about trauma really is nothing compared to what these are South Africans who lived in a terror state for decades. And I know you guys have been to South Africa. If you go to the church, there were black, coloured and white people. That's how the government organised racial differences. And no black person really had any psychiatric access and any access to mental health services. But if you went to I went just after apartheid the first time, and if you go to a church, you know, I'm a lapsed Anglican. I go to church, and this wasn't church. This was amazing. You know, you would be pulled into dancing and singing in community, physically engaged. And I think that's a hint about how we have to rethink trauma through the body more. Thank you.